very excited to welcome Dr. Somava Saha to talk about addressing diabetes, COVID-19, and health equity in Rhode Island. Dr. Saha, also known as Shoma Stout, has dedicated her career to improving health, well-being, and equity through the development of thriving people, organizations, and communities as a primary care doctor, public health professional, and system transformer. She is the founder and executive lead of Wellbeing and Equity in the World, also known as We in the World, as well as executive lead for Wellbeing in the Nation, or the WIN Network, which work together to advance intergenerational health, well-being, and equity. Over the last 5 years, as vice president for the Institute for Healthcare Improvement, Dr. Saha founded and led 100 Million Healthier Lives, which brought together more than 1,800 partners in more than 30 countries, reaching more than 500 million people to improve health, well-being, and equity. Previously, Dr. Saha served as vice president at Cambridge Health Alliance, where she led a system transformation that achieved breakthrough outcomes and won numerous national awards for improved outcomes in health outcomes and cost for a safety net population. In 2012, Dr. Saha was recognized as 1 in 10 inaugural Robert Wood Johnson Foundation Young Leaders for her contributions to improving the health of the nation, and in 2017 was selected as a Leading Causes of Life Global Fellow. She is on faculty at Harvard Medical School, Center for Primary Care, also the Institute for Healthcare Improvement, and the Governance Institute. We are privileged to have Dr. Saha speaking with us here today. I'm going to turn it over to Shoma. Thank you.
Thank you so much for the kind introduction, Randy. Are you all able to see my screen?
Yes, I can.
Wonderful. First of all, it's such a privilege to be with all of you today because I've had the privilege of, over the last year, really seeing you as a state lean into this moment. I was so moved by Carol Walker's remarks earlier because there are very few places where states are ready to not only acknowledge the kinds of inequities that are so apparent, that are brought to light in the context of the pandemic, but have developed the kinds of assets and collaborations that you have to truly address this pandemic as a collaborative. And so I just wanted to acknowledge and respect the incredible, the years of collaboration that has led you to this point. And share a little bit about my own journey, about how I got to this recognition that we actually can't treat medical illnesses without addressing the underlying drivers of what's creating poor health and inequities. So with that, some of my work began as a primary care doctor and as a vice president leading transformation at Cambridge Health Alliance. And, like those of you who have been working in high functioning primary care teams, we did everything we could to meet the needs of our safety net patients. We were a team of people that belonged to a group of 1,500 patients. And as we worked with them before this visit, during the visit, and after the visit to optimize the care for people with diabetes, we were able to see real changes. We built integrated teams that could meet people's social needs and address their behavioral health. We were proactive in connecting people to services, et cetera, and it had an impact. We watched a 36% reduction in all-cause hospitalizations for all people with diabetes. The problem is as vice president, I could see the overall numbers, and what we were seeing is that the total numbers weren't changing. In fact, they were going slightly up, despite all this work and this clear benefit to our patients. So I began wondering why, and that beginning to asking the why and really digging behind the asking the 5 whys has led me to understand that we need to shift our frame. The first part of that frame shift for me came in plotting out how many people got diabetes during this time. And it turned out that while we'd reduced hospitalizations by 36%, the number of people who had prediabetes or diabetes had increased by fourfold. And that's based on A1C tests, not some redefinition of diabetes. Now, a third of that was because of Medicaid expansion. We'd simply increased the number of people we were taking care of. But a full 2.5-fold of that wasn't that. And we weren't alone. In fact, when we looked across a step back and I looked at the national numbers, we saw that the American Diabetes Association was projecting that we would go from 1 in 3 to 1 in 2 people having prediabetes and diabetes, just one chronic illness between, at the time, 2014 and 2020. And if we didn't, in fact, what we would go from spending $322 billion to another $200 billion in this time period. And that had everything to do with the fact that everything we were doing was what we could do within our walls, and everything we could do as a healthcare system, trying to do things to coach people and educate people and even expand outside our walls to support people between visits. But there was something else going on that seemed to be creating a tsunami of chronic illness. And if we couldn't figure out what that was, we weren't going to be successful. And as I began trying to figure out where that tsunami was coming from, I began finding these maps all across the nation. The left-hand side is a map of economic hardship in Los Angeles County. This is, by this point, I'd moved over to IHI and was leading 100 million and was hearing from communities all across the nation and all across the world. And it turns out that all across our nation, youth could find these same maps. In fact, these were reproducible. The left-hand side is a map of poverty or economic hardship. The right-hand side is a map of childhood obesity. Now, some of this came from lack of access to grocery stores, but it was, even when you controlled for that, it was different. And when you began to peel back the why, what you began to realize is that if you drew the maps and if you took that right-hand map and fast forwarded it another 30 years, you would see a map of premature development of diabetes and heart disease. And another 10 years, you'd see our high-risk, high-cost patients. In another 10 years, it would be a map that looked like this one on the right-hand side, where people had died 25 to 10, 20, 25 years prematurely from a chronic illness. And that moment, that recognition that everything we were doing to try to address things before the fact, after the fact, after they'd already developed diabetes and its complications, that was important work to do, but we couldn't only do that. That if we only did that, that we would functionally burn ourselves out because we were treating unmedicated poverty. And if we couldn't understand why people were poor, and even more why some places were poor, we couldn't actually get there. It was the first time I came to realize, some of you may have seen the story on the left-hand side of these two boys. I'll call the one on the left Sean and the one on the right Thomas. There were two actual kids who were best friends in kindergarten, and they loved pulling pranks on their teacher. And they got their dads to take them to the barber shop one day to get their head shaved because they thought that they could actually pretend they were interchangeable with one another in running those pranks. It's one of those cases, I always say, a documented cases of racism as an acquired disease. But in reality, what we learn when we know that these two boys who could be born in the same hospital and grow up just 2 miles apart with as much as a 25-year gap in their life expectancy, which means that Thomas might not be around to help his kids instead of being 80, Thomas might not be around to help his kids actually make it through a pandemic. He may not be around to watch them graduate from high school, far less college. In some neighborhoods, he might not be around to watch his kids graduate. And when you think about what that means to have generational loss, truly, if you die at 55, on average, or 60, and you're not around to be there for those next two generations, what does that mean in terms of the loss in a community? And I just, as we began to think about that and recognize that, in fact, we can predict that in every urban area, in every community, in rural areas across our nation, that's an evidence of a system that's in place that's creating inequities. And in fact, what we now know is that those systems have to do with policies of residential segregation, our histories of racism and colonialism and slavery that went past the abolition of slavery to the way in which they persisted in our systems, from legacies of redlining, where we drew red lines around places that have inequities, that had high levels of minorities. Banks said they wouldn't give loans to them, and mortgage associations said they wouldn't give mortgages, which meant that those places didn't actually have the kind of wealth that they needed. They didn't have access to jobs or access to the tax base to have healthy schools, the great parks and clean streets, and to fix broken lights, the things that create the conditions for health and well-being and for a life where one isn't living every day trying to figure out how you address inequities. And this, for me, was the first time really understanding the system that's in place in every community, in every part of our nation, helped me understand that the well-being of people, of individuals and families that I was taking care of as a primary care doctor, the well-being of the places that I was working with the mayor and the community leaders and schools and others to care for and improve, and the underlying systems, the policies and investments and the legacies we had developed was fundamentally interrelated. That was the first moment that I realized we needed to shift our frame if we were going to be effective. Because if otherwise, if we just focused here on the people in front of us, we could do everything we could to improve their health and well-being, and it would make a difference. You saw that 36% reduction in all-cause hospitalizations. We are so proud of that. But it was sort of like we were missing that big tanker full of gasoline going into the fire while we had organized ourselves to be the best organized bucket brigade trying to put out the fire. And then another analogy that I found really helpful was the idea of the two escalators. That if you imagine two escalators, one going up and one coming down, imagine that if you have advantage, and that could be advantage because of your racial identity, your income, what you had around you, or the place you're growing up. It's as if you are on an up escalator if you have advantage. And if you're on that escalator and you run up really fast, you're going to make it up to the top faster. But if anything happens to you where you happen to trip, you aren't able, you get tired and you can't stop, keep running, you have to help, you get sick, or you have to help somebody behind you who's sick, or has something happen to them and you have to stop running, that escalator will still take you up to the top. So it's not that individual effort doesn't matter and that education and those things don't matter. It's that there's still a system of advantage that's taking you up to the top. If you're on the down escalator and you're trying to run up that down escalator, again, your individual effort matters. And if you run really fast, and you can run really fast, you may be still able to make it up to the top. Now, many studies have shown that you might still actually have significant impacts in terms of allostatic stress that still raises your blood pressure. It's why we see college and PhD educated Black women still having 4 times as much of maternal mortality than others. But the issue on the left-hand side is if anything happens where you're unable to keep running up that escalator as fast as you were, you get sick, you get hurt, you need to help someone behind you, and you stop running or stop running as fast, you're going to start coming right back down. And that is what I describe as a system of disadvantage. And I think if we can't begin to understand that, what we begin to see when we look at most of our efforts to help people, especially those to address inequities, most of what we're doing is catching people as they're falling off that escalator. We don't do a lot. Sometimes we're even helping to pull people up that escalator or push people up the escalator. But I think if we were really thinking strategically in health and healthcare, given that health occupies 1 in 5, a fifth of the economy, I think we should perhaps consider using our power and privilege to actually think about how we reverse the direction of the escalator so that our primary care teams and our community health teams and our community organizations, like what if we came together to really think about what that could look like? Now, there have been some ideas of what that could look like. Now, Auerbach and Castrucci proposed this idea of that we needed to do downstream work, which is providing good clinical care, but also do midstream work, which is about addressing individual social needs, and then think about upstream work, which is about working across a community to change what we call the vital conditions or social determinants of health. To this, we've added this idea of groundwater. The groundwater is to recognize and name those underlying inequities of race and place and other inequities that are structural, and to address those. So how can we begin to do that? We'll talk a little bit about that in a moment. Now, lest you think this is all about what's happening nationally and not relevant, you've already heard some of these statistics. You can see that Black, Latinx and others represent a small proportion of the population in Rhode Island. In fact, less than Rhode Island is the blue bar. You actually have a larger proportion of people who are white than in the rest of the United States. But when you look at your numbers of who is reporting poor health outcomes based on race and ethnicity, the people who have the poorest are Native American people, followed by, closely followed by Hispanic and Black non-Hispanic. White people, in fact, are doing well comparatively. And that burden continues when you look at diabetes and the disproportionate rates of diabetes in people who are Black, Hispanic, versus those who are white. And when you really, the orange line here is the percent who has diabetes in that group. And you see here that if you look at the census tracts of the places that have the highest levels of diabetes, that actually maps to places as well. When you begin to look at it by income, you similarly see that people with diabetes in Rhode Island are far more economically insecure. If you're less than 200% or 200 to 399% of people with diabetes versus those who are greater than or equal to 400%. The poor and those who are Black or Latinx or other races, Native American, suffer a disproportionate level of chronic illness and poverty together. We've seen, you have just heard the numbers of inequities in the context of COVID. This is national by the Commonwealth Fund. What we of course see is that we begin to see that Black people living in counties that have disproportionate level of people who are Black have far higher debts. And that has to do with the determinants of place, access to clean water, to wash your hands, the levels of environmental pollution you might suffer if you understand that actually breathing in polluted air because you live by a highway or because you live near factories that have been put in communities of color and you ingest that air over time, you have high levels of asthma and COPD at baseline, and you're much more susceptible to dying from diabetes. This is all data now that's been verified, as well as lack of access to healthcare, to COVID testing, et cetera. In fact, the Federal Reserve has done an analysis that says that the distribution of Paycheck Protection Program dollars represent or could represent, is already seeming to represent a new redrawing of redlining maps today. And I think if we don't take that equity lens, we're going to be left dealing with things after the fact. And it's, many people say, why is it your job as a doctor or a public health professional? I'm like, because these are our patients. We are going to deal with this, and it's going to look like illness, whether that's mental health illness or physical health illness, but really this is going to be driven by root inequities. And so we need to use our voice and our power and privilege to begin to say that that's wrong if we don't want to end up dealing with it after the fact. Because in fact, of course, we know that those maps you saw of diabetes and pre-diabetes, those are same maps, of course, predict who's getting diabetes. And similarly, when you look at COVID and social vulnerability in Rhode Island, Black and Latinx people are the most affected. Those are these two bars, and that they're related to place. This is COVID cases and social vulnerability. And this is based on a map that CDC drew in 2016. We can predict where poor outcomes will be before the fact, and you're not alone. This is true across the nation. I could show you map after map of this. This happens to be in Chicago, Here's that social vulnerability index by census tract. And here you see on the left-hand side, risk scores for COVID, and then the green dots represent deaths from COVID. The health and well-being of people, of places, and inequities are fundamentally interconnected. And I want you to remember that, because a big part of what you've been you've taken this moment of COVID-19, which unveils these societal inequities, to do in Rhode Island is to really think about how you can advance equity in the context of COVID, to lean into this, to say, let's not treat this as diabetes here and COVID here and inequities here. Let's understand these as a connected issues and begin to think about how we address this. One of the models that you've used from 100 Million Lives is Pathways to Population Health, which talks about how we can improve the health and well-being of the person in front of us by addressing physical and mental health and their social and spiritual well-being, both when they're in front of us and in the community, how we can address their underlying ways in which we need to work together in place by building linkages between clinical teams and community teams that and the health equity zones that you've had the foresight to develop, and then how those two teams work together with community residents to address the underlying systems that drive inequity. That is the Rhode Island Diabetes Health Equity Challenge, and we'll talk about that in a moment. But I just wanted to call out that this addressing physical and or mental health needs has to do with downstream. This addressing social and or spiritual well-being, that's midstream. This working on a focused issue that no one can address alone to address community health and well-being is upstream. That is working on focused issues like COVID and diabetes together. And then groundwater is that portfolio 4 is about addressing those root causes. Now, the Rhode Island Diabetes Health Equity Challenge was designed to help teams that are made up of community teams and primary care teams working together with community residents and, of course, community health teams made up of community health workers that are from the community in a place-based way, work together to think about how they can launch an upstream, midstream, downstream, and root cause strategy together. What they did was we used Pathways to Population Health as a guide, began to understand the needs of the community and to figure out what we can do. And I have to say, I've been so inspired by the two teams that have launched into this challenge. EPCAP, led by the East Providence has been as extraordinary at integrating the voices of people with lived experience and bringing together people across the community health teams and the nurse manager and others. They began by mapping their needs and assets and saw that they had assets in telehealth and COVID testing, diabetes educators and farmers markets, mentoring and coaching for seniors, looked at AARP support for technology, green spaces. This work isn't just about knowing that there are deficits, it's about recognizing that together you have many more assets than you might. But they also identified that there were real inequities in medical and non-medical transportation, in access to nutritious food and housing issues and mental health. They started with access to nutritious food, knowing that they were going to do more. And in each of these areas, they began partnering with transportation vendors, with food pantries to introduce fresh fruits and vegetables, housing issues, and mental health issues. Integra began more by thinking about what's a program that they could do, and realized very quickly that they needed to do things related to diabetes. But when they began working together with community organizations in their area, that they could work with FSRI, with Progreso Latino, and with others in the list to begin to think differently about what they could do. They identified behavioral health, food access, and diabetes education as a place to begin, and began working to think about how they could both deliver meals and packages to community residents with diabetes that were having poor outcomes, but to then think about how they could address this in terms of underlying issues. In this next phase, we're going to be getting much more strategic and expanding the cycle to really think about what it looks like to address this in take this from downstream action to midstream action, which is where we are, to how we begin to change community conditions, like those healthy food banks, to addressing root causes. And I just wanted to leave you with an example of another team that's doing that in the south of Texas. Now, in the south of Texas, Methodist Healthcare Ministries took the same moment to begin to say, what's going on? And as they realized that COVID cases, child poverty, COVID unemployment, and health status all track together in same areas, they began to keep working in the urban area they were in, but began to really take on some of the rural areas that are most affected by inequities, where public health infrastructure was not as robust. And they began thinking about how they invest and support that infrastructure. To begin to think about community funding. They moved a lot of funding to emergency food relief, but have begun thinking how they can work with those food banks and food policies to actually, pulgas, which are markets in the area that many community residents go to think about healthy access in a way that's culturally appropriate where people go. The second part of what they began doing is really thinking about those building civic capacity in communities to address their own issues, even as they look at investing in community health teams in those areas. And the third is they began focusing on cross-cutting reverse the escalator strategies. And they identified that intergenerational poverty, the digital divide, would be cross-cutting, that those could help break the cycle of poverty over time. And as they looked at both anchor strategies, where they look at where they get people jobs and how they can get others to do that, as well as policies to begin to create change, and direct supports through, for example, the Family Independence Initiative to directly give money to families with the recognition that families in poverty actually, for the most part, if you look at the data, actually know what to do with the money. They can use it much more efficiently to be able to address what they need, to recognizing that in the context of huge lack of broadband in much of the areas, families lost access to jobs, to health, and to education together. And that they needed to partner with others like the Federal Reserve, LISC, and others to address this, but together they could. And that's where they began to really bring other partners together to think about. And fundamentally, they committed to a transforming from the inside strategy to address racial equity directly in their own people, processes, and outcomes. And the south of Texas might not be where you think about innovative change coming from, but I want to let you know that the journey you're on, you're not alone in, and that communities across the nation are beginning to take this on in a way that's serious. And I think that's what I want to commend you for, is the seriousness of your effort to take this and not just to keep it to two teams, but to really think about how this across Medicaid, Department of Health, and the community becomes a strategy to advance equity in Rhode Island. I'm going to leave you with the words of our first Youth Poet Laureate, Amanda Gorman, The Miracle of Mourning. I've included a link to this, the whole poem. I encourage you to read all of it and listen to her voice. But these words strike me every time. She wrote this in the context of the pandemic. She wrote, "While we might feel small, separate, and all alone, our people have never been more closely tethered. The question isn't if we will weather this unknown, but how we will weather this unknown together. So on this meaningful morn, we mourn and we mend. Like light, we can't be broken, even when we bend. As one, we will defeat both despair and disease. We stand with healthcare heroes and all employees, with families, libraries, schools, waiters, artists, businesses, restaurants, and hospitals hit hardest. We ignite, not in the light, but in lack thereof. For it is in loss that we truly learn to love. In this chaos, we will discover clarity. In suffering, we must find solidarity." Thank you so much for having me here. But above all, thank you for doing the courageous work that Amanda calls us to come together in solidarity to meet the needs of those who experience inequities.
Thank you so much, Shoma. What an honor to be working with you as we walk through this journey together. And your words underscore what Carol shared earlier, what we've all heard our director echo, as well as our governor, especially over the past however many months we've been going through this pandemic. we're just about out of time, but I do know that we have a question in the chat. This is from Anna Bertarelli, thanking you. And she says, it has been said, COVID-19 brought to the forefront of public health the obvious disparities and inequalities in health. How do you propose, once we are over the epidemic, we sustain the awareness and work in these disparities and inequalities?
I think we have to start by saying we actually can't go backward, that we actually can't afford the cost. We never could, even before the pandemic, afford the cost of persistent inequities anymore. And if we lean into this moment to say that when we build and renew, we really renew on a foundation that is so deeply committed to addressing equity that we make that a core part of the design of everything that we do, not just in the health sector, but across sectors. And I think if we can recognize and take the veil off our eyes, we can't unsee the things we've seen. And we need to commit to that journey as a long-term sustained journey. We didn't get here overnight. It's going to take time. But if we can commit to that journey together and lean into that at every step, I think we have a chance of turning the trajectory of where we go as a nation.
Yeah. And as you mentioned during your presentation, we have started to embark on that journey years ago with our health equity zones here in Rhode Island. And now more recently with the community and clinical linkage piece, which you're helping us to shepherd through, in different communities throughout the state. So thank you for that. Thank you for being with us here today. So appreciated.